All right, welcome. Today, we're going to do a serious deep dive into one of the most common conditions out there, gastroesophageal reflux disease, or GERD. We're going to move way beyond just the basics of heartburn and really explore the science, the diagnosis, and the pretty sophisticated ways we manage this complex disease. I want to start with just one number, 20%. That's the estimate of how many people in the general population are affected by GERD. Think about that, 1 out of every 5 adults. So this is clearly not just some minor inconvenience. It's a massive, widespread condition that really impacts public health and, of course, people's quality of life. So to really understand GERD, we're going to walk through 5 distinct chapters. First up, we'll define it and look at who it affects. Then we'll get into the why, the pathophysiology. After that, we'll cover how it's diagnosed. Then the really crucial part, prognosis and complications. And finally, we'll wrap up with how we manage and treat it. Okay, let's get right into chapter 1. Because before we can even think about treating GERD, we have to have a super precise definition and really understand the landscape of who is most at risk. Now, what's really important about the official definition here is what it emphasizes. Notice it's not just about reflux happening. The absolute key is the impact. The reflux has to cause symptoms that are troublesome or lead to actual physical complications that mess with a patient's quality of life. That's the line in the sand that separates normal physiological reflux from the disease we call GERD. And you know, GERD isn't just one thing. It actually shows up in 3 main forms, what we call phenotypes. The huge majority of patients, about 65%, have what's called non-erosive reflux disease, or NERD. That means they have all the classic symptoms, but if you do an endoscopy, their esophagus looks perfectly fine, no visible damage. Then you've got about 30% with erosive esophagitis, where the acid has actually caused visible inflammation and sores. And finally, there's a smaller but really critical group, about 5%, who develop Barrett's esophagus, which is a precancerous condition. So who's most at risk here? Well, the data paints a pretty clear picture. Obesity is a huge driver. It increases the odds by 73%. Smoking definitely plays a role too. And while the symptoms can affect anyone, men seem to be at a higher risk for those more severe complications, like Barrett's and cancer. And as you'd probably guess, being over 50 and having a long history of symptoms, those are major red flags. Okay, that brings us to chapter 2. We've talked about the what, so now it's time to dig into the why. What is actually going wrong in the body that causes GERD in the first place? The single biggest culprit, the most common mechanism, is something called a transient lower esophageal sphincter relaxation, or TLESR. The easiest way to think about this is to picture the lower esophageal sphincter as a little muscular gate between your stomach and your esophagus. With TLESRs, this gate just decides to relax and open up when it's not supposed to, not because you're swallowing, but just randomly. And it's often triggered when the stomach stretches out after a big meal. The gate is open, and that's the problem. So, the gate is open, but what's waiting to rush through it? This is where this fascinating and kind of scary concept of the acid pocket comes in. See, after you eat, the food in your stomach acts like a sponge, buffering most of the acid. But a nasty little layer of highly acidic, pure, unbuffered gastric juice just floats right on top, right next to that sphincter gate. And in people with GERD, this pocket of pure acid is sitting there perfectly positioned to shoot upwards the second that gate relaxes. It's really a cascade of failures, a domino effect. First, the barrier fails. That's our TLSRs. Second, you have these aggressive factors from the stomach, like the acid pocket ready to attack. Third, the esophagus itself isn't great at clearing out whatever comes up. Its muscular contractions are too weak. And then finally, the lining of the esophagus itself just gets worn down and compromised. And that's what leads to the inflammation and all the symptoms. Now that we've got a handle on the mechanics, Chapter 3 is the logical next step. How do we actually identify and diagnose GERD in the clinic? And this leads us to a really central question. With symptoms as common as heartburn, how does a doctor go from a patient just saying, "I have heartburn," to a definitive, objective diagnosis? Because it turns out, just relying on symptoms alone, it can be pretty misleading. The accuracy is only around 70%. So clinicians have a whole toolkit of tests. The simplest one is called the PPI test. Basically, you try a course of powerful acid-suppressing pills and see if you feel better. The gold standard for actually seeing the damage is an endoscopy. But for a truly definitive diagnosis, especially when there's no visible damage, ambulatory pH monitoring is the key. This is where a tiny probe actually measures acid exposure in the esophagus over a period of 24 to 96 hours. And there's a very logical flow that clinicians follow. For a patient with classic symptoms, no red flags, a trial of PPIs is a totally reasonable first step. If that doesn't work, or it only kind of works, then it's time for an endoscopy to go looking for evidence, like esophagitis. And if that scope is totally normal, but the doctor still really suspects GERD, the final step is that objective pH test to get a conclusive answer, one way or another.
Okay, this next chapter is absolutely critical. Before we even talk about a single treatment, we have to understand the stakes. What happens if GERD is just left to do its thing, unchecked? Understanding the prognosis and the potential complications is what gives this whole thing a sense of urgency.
I'm just going to let this quote from the source material sit there for a second. This is not just about being uncomfortable. Chronic, untreated GERD can lead to scarring that actually narrows the esophagus, causing a stricture. It can cause bleeding. And, most ominously, it can lead to Barrett's esophagus and ultimately esophageal cancer.
This timeline here shows that dangerous path. It all starts with chronic reflux. Over time, that can cause erosive esophagitis. Now, in some people, the body responds to this constant injury by changing the actual cell type of the esophageal lining. That process is called metaplegia, and the result is Barrett's esophagus. The problem is, this new tissue is unstable, and it has a much higher risk of progressing to esophageal adenocarcinoma, which is a very deadly cancer.
Which brings us finally to our last chapter, management and treatment. Knowing all the risks, how do we actually get GERD under control, manage the symptoms, and prevent those terrible complications we just talked about? The absolute foundation of treatment is lifestyle changes. For overweight patients, weight loss is number one. Quitting smoking is essential. And some simple mechanical tricks can make a huge difference, like propping up the head of the bed, not eating too close to bedtime, and even sleeping on your left side to physically keep reflux down.
Now, on the medication front, we have two main classes of acid suppressants. For decades, the workhorse has been proton pump inhibitors, or PPIs. But there's a newer class, PCABs, that have some pretty big advantages. They work faster, they provide more powerful acid suppression, and, this is a big one, their effectiveness doesn't depend on when you eat. That makes them really useful for severe cases and for controlling those tough nighttime symptoms.
But what about when the treatment just doesn't work? So-called refractory GERD is really common, but a lot of the time it's not actually the medication that's failed. It's crucial to look for other causes. Is the patient even taking the medicine correctly? Or could it be something else entirely, like eosinophilic esophagitis? Or maybe a functional disorder where the esophagus is just too sensitive? And this is a huge concept in modern gastroenterology. For a really large group of patients with stubborn symptoms, the problem isn't too much acid. It's that their esophagus is hypersensitive to even normal amounts of acid. For these people, just throwing more acid suppression at them is never going to work. The treatment has to target the nerve sensitivity itself, using things like neuromodulators or even psychological therapies. And that leaves us with this final, kind of provocative thought. For decades, our main strategy has been to manage the attacker, the acid. But if the real root cause is a mechanical failure of that anti-reflux barrier, then maybe the future should focus more on fixing the barrier itself. Whether that's through new endoscopic procedures or surgeries, the ultimate solution might not be in neutralizing the attack, but in rebuilding the defense.